Good morning, everyone. I'm Tom Russo, and a special good morning to the 100 or so individuals joining us this morning through our webinar. Today's event is jointly sponsored by the Office of Industry Corporate Research, in the Office of the Vice President of Research here at GW, the Milken Institute School of Public Health, and ICF International. We have a great program for you today, and before we begin, just a few reminders. For those of you who want to join us on the conversation on Twitter, use hashtag GWICF2015. Following the panel discussion, we will have Q&A from the audience here and for those joining us on the webinar. And again, the same hashtag GWICF2015. I would now like to introduce our next speaker, the president of George Washington University, Stephen Knapp. Stephen Knapp became the 16th president of George Washington University in August 2007. His priorities include enhancing the university's partnership with neighboring institutions, expanding the scope of our research here at GW, strengthening our worldwide community of alumni, enlarging our students' opportunities for public service, and leading our transformation into a model of urban sustainability. So please, ladies and gentlemen, join me in welcoming President Stephen Knapp.
Thank you, Tom. Ladies and gentlemen, good morning. It's a pleasure to welcome you to the George Washington University for the 4th GW-ICF International Research and Evaluation Forum. I'd like to extend a special welcome to Sudhakar Keshavan, who is the chairman and CEO of ICF International, and a really great friend of the university, Dr. Robert Croyle, who's the director of the Division of Cancer Control and Population Sciences at the National Cancer Institute, and our audience members who are participating through the webinar, because a number of them are watching this online and through the webinar. I'd also like to welcome our distinguished panelists. You'll hear more formal introductions of them in just a few minutes. This quarterly speaker series has been developed through George Washington's valued partnership with ICF International. ICF International was founded as the Inner City Fund. Its first president was Clarence D. Lucky Lester, a former Tuskegee Airman. Today, it's a global professional services company that continues to honor its founder. George Washington and ICF have joined together to pursue research opportunities in the areas of federal health programs that include bioinformatics, public health preparedness, genetics and genomics, and survey methods. The GW-ICF partnership is a model, I believe, for working relationships between academia and the private sector seeking to address pressing challenges. And I think this kind of partnership is going to become increasingly important as the challenges of rising healthcare costs continue to emerge, and of course, as the entire system is redefined because of the changing market dynamics brought about by the Affordable Care Act and many other factors. And so we look forward to developing this partnership into the future. Our speaker series is focused on relevant issues in healthcare affecting academia, government, and the private sector. Its previous topics have included obesity prevention and control in the workplace, M-Health, that is health-related services delivered via mobile communication devices, and public health challenges related to increased e-cigarette use. Today's discussion focuses on how combining cancer control with population science can reduce the risk of cancer, its incidence, and also deaths from cancer. George Washington has refocused and re-energized efforts in cancer research and patient care in a number of ways, and most recently through a very important initiative, which is the creation of a comprehensive cancer center led by one of the panelists you'll hear introduced in a moment, Dr. Eduardo Sotomayor. That center is now the umbrella for all cancer-related activities, including clinical services, as well as research at George Washington. I know you'll profit from this discussion. I hope you'll enjoy it. And now I'm pleased to welcome to the podium Dr. Jeffrey Ackman, who's the Vice President for Health Affairs and the Dean of GW's School of Medicine and Health Sciences. He will introduce our panelists. Please enjoy the discussion. Thank you very much for being with us.
Have a good day. Good morning, and thank you, President Knapp. Thank you and welcome this morning. Thanks for being here. Thank you to Tom Russo for organizing this program. I'm honored to introduce today's panelists. Dr. Robert Croyle serves as the Director of the Division of Cancer Control and Population Sciences, the National Cancer Institute of the NIH. It's a division of the NCI that covers a wide range of scientific domains and disciplines, including epidemiology, behavioral science, surveillance, cancer survivorship, and health services research. The division is a nexus for research into the genetic, sociological, and psychological factors that drive everyday decisions influencing an individual's risk for cancer, with one goal in mind: to identify the most effective means of reducing each person's risk for cancer. Dr. Croyle is responsible for overseeing a research portfolio and an operating budget of nearly $500 million and serves on the NCI's Scientific Leaders Committee. Prior to taking on the director role, he served as the division's associate director for the Behavioral Research Program, leading its development and expansion. Dr. Croyle joined NCI from the Huntsman Cancer Clinic at the University of Utah, where he was a professor of psychology, and prior to that, at the University of Washington. In his own research, Dr. Croyle has examined how individuals process, evaluate, and respond to cancer risk information, including tests for inherited mutations in BRCA1 and 2. He is a widely published author in scholarly journals in the area of behavioral sciences, public health, and cancer. He's co-editor of the Cancer Control and Behavioral Science and co-editor of Making Data Talk, communicating data to the public, policy matters, and the press. He's also a graduate of the University of Washington and Princeton, and he is a member of the Academy of Behavioral Medicine Research, a fellow of the Society of Behavioral Medicine, a fellow of the American Psychological Association, and a recipient of many awards for his research and professional service. It's really a pleasure to have Dr. Croyle with us here today. Good morning. Next, I'd like to introduce a second panelist, Dr. Eduardo Sotomayor, who serves as the new director of the GW Cancer Center and professor of medicine in the GW School of Medicine and Health Sciences. Dr. Sotomayor joined GW in July 2015 with the vision of leading GW's efforts towards NCI designation as a cancer center. Internationally recognized for his work in mantle cell lymphoma and immunotherapy, Dr. Sotomayor joined us from Moffitt Cancer Center in South Florida, where he served as the Susan and John Sykes Endowed Chair in Hematologic Malignancies and was a professor of oncologic sciences and of pathology and cell biology at the University of South Florida College of Medicine in Tampa. He also served as the scientific director of the DeBartolo Personalized Medicine Institute at Moffitt. His basic and translational research focuses in the immunobiology and immunotherapy of B-cell malignancies. And Dr. Sotomayor has published more than 100 manuscripts in highly prestigious journals and currently is the recipient of 3 NIH R1 awards. Dr. Sotomayor is also a member of the Scientific Advisory Board of the Lymphoma Research Foundation, is a member of the Executive Committee of the Mantle Cell Lymphoma Consortium, and is a standing member of the National Cancer Institute's Initial Review Group Subcommittee on cancer centers. Welcome, Dr. Sotomayor. Finally, I'd like to introduce my colleague and fellow dean, Dr. Lynn Goldman, who serves as the Michael and Laurie Milken Dean at the Milken Institute School of Public Health at GW. Dr. Goldman is an internationally recognized epidemiologist, pediatrician, and public health official, and she will serve as today's moderator. Dr. Goldman joined GW in 2010 from Johns Hopkins University, the Bloomberg School of Public Health, where she served as a professor in environmental health sciences. She also held positions as the assistant administrator for the EPA's Office of Chemical Safety and Pollution Prevention, and served as the head of the Division of the Environmental and Occupational Disease Control for the California Department of Public Health. A graduate of Cal Berkeley, Johns Hopkins, and UC San Francisco, Dr. Goldman serves on the board of the Environmental Defense Fund and is a member of both the Institute of Medicine, where she also serves as a member of the Governing Council, and the National Academy of Sciences Board of Environmental Sciences and Toxicology. It's a pleasure to turn things over to Dr. Lynn Goldman. Lynn?
Thank you, Jeff. Thank you so much. It's It's really a great pleasure to be here with you today and have an opportunity to moderate this panel with two such distinguished speakers. And also, I think, to highlight what is going on here at the George Washington University with cancer research and cancer prevention. This is really an exciting moment that we are experiencing today. We are on the verge of, for the first time ever, having a united effort across this university in not only research and clinical care, but also prevention of cancer, and much due to the presence now on our campus of Dr. Sotomayor. Just last Friday at the School of Public Health, we had a wonderful retreat where we spent an entire day, the faculty and public health, the faculty from medicine, nursing, and other parts of GW, focusing on population health, focusing on policy, the opportunities to create new collaborations, and to build this area within the university. And therefore, I'm very excited that today we're here talking about building bridges between clinical and population health in addressing cancer. We have so much to do given our location here in the District of Columbia, right? Absolutely. I mean, we live in a city that has enormous disparities when it comes to cancer. The cancer incidence, the cancer mortality is well above national averages, and there's certain cancers like prostate cancer, breast cancer, cancer of the liver, cancer of the uterus, that are much higher here, both incidence and mortality. Mm-hmm. So we are faced with a challenge and also an opportunity to address that. I think we are also, given our location in Washington, D.C., uniquely situated to be able to create models for population health and cancer prevention for the country, but also to engage in cancer issues globally. And with the emergence of non-communicable diseases as having a greater and greater burden of disease across the world, I think that cancer is going to be coming to the fore. It's not only a local health issue, a national public health issue, but also increasingly an important global health issue. So with that, I want to start to engage in some discussion with our panelists and start with the topic of what's now called precision medicine. It used to be called personalized medicine. We're all aware that the National Institute of Health, and in fact the White House, has taken precision medicine as a major initiative that is going to direct a lot of the new funding for research, and also that is staged to somehow impact on clinical practice in the future. We know that many of the diseases that are most commonly experienced, especially cancers, that we've taken a kind of a one-size-fits-all to treating patients. We know that we can do a better job with some of the science that's emerged. But I'm wondering, and I'm going to turn first to Dr. Sotomayor to address this, where do we see personalized medicine, and particularly the initiative, as potentially having an impact on cancer and the practice of medicine, and also how does it bring us together, I guess, across this crossroads, between clinical medicine and population health?
Thank you, Dr. Goldman. Good morning. It's a pleasure to be here today. So I am a practicing oncologist, and let me start by saying that the best approach to cancer, the best treatment, is prevention and early detection. So I would like less patients to come to see me, because when they are in my office, so basically they have what we call advanced cancer. And so when I explain to my patients about cancer, I say it's like reading a book. So there is a book with 10 chapters. And currently, most of the investment that we make in cancer is on the last chapter of this book. So which means investing our dollars in, which is good investment, in treatments, and diagnosis, treatment, survivorship. But so we need to start focusing on prevention, lifestyle, and diet. And I think that the short answer to your question about where is the impact of precision medicine going to be is in the area of prevention and early detection. So when the president announced the Precision Medicine Initiative. So there was one word that is very important in that announcement is personalized information. So what we are trying to create is a health information system in which we are going to have two important set of data. What we call the phenotypic data, in which we're going to have demographic, health styles, lifestyles, diet, and also we are going to have genetic data. So these days, so we have the technology and the analytical tools to identify what's wrong with the cancer cells. So there are several alterations in the cancer cell that we call mutations. So now we have the technology to detect those mutations. So when we talk about precision medicine, there are two misconceptions. One is that precision medicine or personalized medicine is all about genetics, and that personalized medicine is all about treatment. It is not. So personalized medicine is about prevention and cancer treatment, and also incorporates genomic data together with the effect of the environment on a person. So I think that the major impact of precision medicine will be to understand so population at risk, so what are their genetic makeup, how the lifestyles, diet influence those genes, and how is that going to contribute to the cancer development. So therefore, so precision medicine will influence significantly the area of cancer prevention, especially in those populations that are for a high risk to develop cancer.
Do you have anything to add to that?
Yeah, I think that it's also really clear that in order to kind of leverage all these scientific advances we keep hearing about, that we need a more integrated, coordinated approach across the sciences. So just as we've had this traditional divide between prevention and treatment, we've also needed to build better bridges across the basic clinical and population sciences. So one of the reasons at the NCI, at the Cancer Institute, why we've invested a lot of funds the last several years in transdisciplinary team science is to really increase the speed by which we accelerate progress from discovery to application. And one of the rate-limiting steps we're seeing within that context is the delivery of evidence into care, particularly in underserved settings. So this has to do with training of providers, of effective health communication, but also creating the right healthcare and policy context so that our healthcare systems are better enablers to leverage all this new science.
Thank you. So, a lot of I think the focus in that last discussion was on the primary prevention of cancer, preventing it before it starts in the first place, the secondary prevention, better attention to screening, early diagnosis, getting people into treatment earlier. But we know that now a lot of people are surviving cancer. They're surviving cancer for a long time. And now I think that we're seeing that we need to focus also on tertiary prevention, and that is the prevention of disabilities among those who survive, or at least the achievement of optimal health among survivors. And Dr. Croyle, I know that you have been involved with that the NCI has been very involved with that. I was wondering if you could share a little bit with us about the approach that you've been taking.
Well, it's interesting that the history of work on cancer survivorship really began with advocates. It was really cancer survivors themselves that advocated a number of years ago that the National Cancer Institute should create an Office of Cancer Survivorship and devote more scientific time and attention to the issues of cancer survivors. So we have over 12 million survivors in the country, and the challenges faced need to be as informed by science as all of our other approaches to cancer. So that means long-term side effects of cancer treatment, which we've known about for some time, but also issues of the trade-off, the handoff of a patient from an oncologist to the primary care setting. So one of the things that's become clear as we've listened to cancer survivors about the issues they encounter in their long-term care is we need better communication among the providers themselves, and also a better understanding of these long-term side effects of cancer treatment. Another challenge that cancer survivors talk to us a lot about is the economic burden of cancer on their personal lives, the out-of-pocket costs that they incur, loss of time on the job, impact on career, and impact on family, which is really key in cancer. So as cancer becomes more and more commonly a chronic disease, then we need to approach it as such, and that it's not just an issue of the specialist, but also it's an issue of the entire healthcare system and family providing adequate support for survivors.
It's interesting. I mean, as a pediatrician, I've been particularly concerned about the fact that as children who survive cancer treatment grow up, they no longer are seen by their pediatricians. Mm-hmm. And the ability of our healthcare system to clearly track that, not only that they had cancer, but how they were treated, what kind of therapy that they had. Is it possible to make progress along those lines in terms of making that information, if you may, more durable for these children, many of whom were so young when they were treated, they may not even be aware of what kind of therapy they had.
Yeah, I think that's why now the standard of care is developed to provide patients with treatment summaries and follow-up care plans for cancer survivors. That's something that we haven't been doing before, but we need to increase the degree to which a patient, whether it's a pediatric cancer patient or adult patient, can take their information with them about their course of treatment, what they've been exposed to, and also the recommendations and guideline-based recommendations about follow-up care. Another aspect that's huge, and this includes pediatric cancer survivors, is a lifestyle. We know from data that there are a lot of adult survivors of childhood cancer who smoke, as remarkable as that seems. And so the lifestyle factors, which oftentimes we all hear about in the context of preventing cancer, are just as important in surviving cancer, both short-term and long-term. And one of the things we recognize we need to do at the NCI is to support more research to generate evidence on what are the effective strategies to modify lifestyle, not just to prevent cancer, but also to prevent its recurrence as well.
Right. What I want to add is that so in our clinic, we had a multidisciplinary approach to cancer survivors, which involves the physician, but also the primary care, internal medicine, social worker, psychologists, because we need to see the patient, the survivor, to have a holistic approach. It's not about, okay, so your disease is in remission, but so we need, the social worker, we need counselors to tell the patient what needs to do in order to change their lifestyle, their diet, or in order to try to keep them in remission. So I think that one of the major messages that we received from the NCI was to promote this team approach to the management of survivors. And the positive news is that in the last 20 years, we are seeing significant advances in treatment, and so we are seeing more cancer patients surviving this disease, which also creates some pressure into the financial management of these patients.
Yeah, there's been a lot of discussion about the coordination of care components in the Affordable Care Act. A lot of that discussion was driven by cancer patients and issues of cancer survivors. That is how to facilitate coordination and care and empower patients to really make sure that their providers are talking to each other. And along the lines of the earlier point you mentioned, we just released a new announcement from NCI that we're interested in funding more research on cardiotoxicity, which is a great example of kind of the handoff between different providers, and that is really engaging the science of cardiology in cancer survivorship, because many of the late effects do impact the cardiovascular system.
Well, you mentioned the lifestyle factors, and that is one area that we've done research in the School of Public Health in terms of the diet and physical activity, and trying to not only maintain, but if you may restore to a higher health status. So many people who survive have seen long-term decrements in health because of being inactive, and as you say, the cardiotoxicity, other kinds of toxicity. But it's a great area for research, where I think we can make a difference in people's lives. Eduardo, I wanted to turn to you to start off a little bit of a conversation about underserved populations. I mean, I think I mentioned at the beginning the fact that we do have these remarkable health disparities that, certainly our community versus other communities, and then within our community, if you segment our community by socioeconomic groups, by race, by, if you may, looking at the LGBTQ community versus others, that we see these huge disparities. And they're a complicated series of issues around certainly lifestyle, but also access to screening. Even after people have had screening, the ability to quickly get into treatment and to stay in treatment. And how will we approach that? What are our opportunities, I guess, as an emerging cancer center here in Washington, to be able to approach those disparities issues?
So let me start by saying there is a top priority at the GW Cancer Center to provide access to underserved populations. So recently I attended a meeting in which, so we are all excited about the new medications, immunotherapies. So we are curing more cancer patients, but there are areas in this city in which the patient with cancer, so basically they cannot think about cure. They cannot think even about treatment. And I think one of the major goals of the GW Cancer Center is to working with the School of Public Health and also work with a new patient-centered initiatives institute under the Cancer Center to find strategies to engage these underserved populations. So for instance, we are going to be working in trying to bring more Medicaid patients to have services in the emerging cancer center. But I think it's very important when we, several have tried to engage these underserved populations, and what is important, being a minority myself, is that we need to gain the trust of these populations. The African American population, the Hispanic populations, so they want to see us working with them. So they don't want a top-bottom approach to engage them in their cancer care. What they want is to be participants and be sort of bottom-up approach, and I think that that's what we will try to implement at the GW Cancer Center.
Yeah, I think this movement we've seen in communities around the country in terms of the integration of medical and public health services with social services is a really important trend. And the nonprofit sector has played a key role in this. Robert Wood Johnson Foundation, many of the NGOs based here in DC as well. So within the public health realm, there's been a long recognition of the social determinants of health and the weight of those. What's been changing is we've seen a lot of basic and clinical scientists become engaged in health disparities as research questions, because we're seeing different biological differences. For example, the different frequency of some gene variants in different subpopulations. We're learning about the importance of ancestry in terms of risk of diseases like prostate cancer, and the heterogeneity of the American population, and the complexity of the social circumstances under which people live, work, and play. Capturing the full complexity of that as part of the cancer research enterprise is really essential. And part of that is trying to get the scientific community to look at each other in a broader and more diverse way as well. We need diversity among the disciplines taking on the cancer problem, just as we need diversity in our clinical trials enrollment and how we engage communities as well. Because I think there's going to be some really new opportunities to develop new approaches, personalized, targeted precision approaches to some cancer subtypes that especially impact some of our least served subpopulations.
So Bob, so I want to, within these new precision medicine initiatives, so 1 million healthy Americans will be enrolled. And so what strategies the NCI is developing to try to also involve minorities? Because I think if after we enroll 1 million patients, we ignore this underserved population, so we are going to have just a partial view of what is relevant in sort of.
Yeah, no, that's a challenge because for a large-scale project like the President's Precision Medicine Initiative, unless you're engaging communities and enrolling diverse research participants, then we're going to be back to where we started. So just last week, the NIH released its first wave of announcements, funding announcements, related to the Precision Medicine Initiative, the National Million Person Cohort Project. But I should also mention that the NCI, the oncology-focused component of the Precision Medicine Initiative, is off and running. The MATCH trial and several of our precision medicine clinical trials had been scaled up. And what's interesting is we're seeing more rapid accrual to these new precision medicine trials than we've ever seen in major cancer clinical trials before. So the interest that they're generating among a variety of communities, and the fact that we can now approach patients and their cancers, not just by where the cancer is, breast or prostate, but by the molecular characteristics of that individual patient's tumor. And that's what's really going to revolutionize our treatment, not only in terms of drug development, but also in looking at all the kind of ancillary effects of cancer at the individual level.
So this, this issue of making clinical trials more accessible to all populations, I think it's a very complicated issue. As I experience myself in my life, that I have friends who are extremely well-educated, highly educated, fairly well-off, and they travel anywhere that they can to get into the clinical trials so that they are sure that they're getting the most up-to-date, the best therapy. And on the other hand, I have interactions with people in the community, including the community near here, who are not well off, not as well educated, who are afraid that being in a clinical trial means that you're being experimented on, that you're not necessarily receiving good therapy. And it's ironic. It's ironic in that your best chance to having the best therapy is to be in a trial, and yet there is a sense in many communities that it's dangerous and you shouldn't enroll in trials. And how will we reach out to engender trust with the communities that are around us to be able to establish that kind of relationship?
So I think that we need to have, I would say, a permanent presence. So try to work with a primary care provider. So that community, so minorities communities have a significant trust for the primary care physician. Yes. That's the only person that they see as the medical person in the community. So therefore, I think that what we need to do as a cancer center is to engage those primary practitioners, train those primary practitioners. So communicating about these initiatives, precision medicine, and the need to enroll minorities into this large cohort that the NIH has started. I think that so working with the primary care physician is going to be significantly important in order for them to trust what we are trying to do. And then when we have the trust, so we can see an increase in the enrollment of minorities in clinical trials.
I think one of the things that's been really compelling in the last few years in our experience with clinical trials, including cancer clinical trials, is when ethnic minority or underserved patients are approached in an appropriate, culturally sensitive way, right, and with effective communication, engaging the family, recognizing people's lifestyle and context, the world in which they live, then there's no less interest in enrolling in a clinical trial. So a lot of it is just a matter of getting access, providing access, and then engaging patients in a way that resonates, regardless of their level of health literacy or prior concerns about health care in general. But it can be done. We know it can be done, and it has been done in several centers and several sectors. We just need to do a better job of making sure that we're not overlooking or we're not assuming there's lack of interest there, because it can be done very effectively.
So, Dr. Croyle, I want to shift now into a slightly different area, but one that's of great interest to those of us in population health, which is policies around screening. And I think we've all been aware of, and many of us, I personally, have been somewhat confused by some of the debates around, for example, mammography, use of mammography. When should it be initiated? How frequently? And the obvious, I think, lack of 100% clarity in the data is probably, I'm sure, what's behind this, as well as the considerable passion that many people bring to that kind of a discussion. But here we are in an era where there are so many new technologies that are being developed. So we now have 3D mammography. We have ultrasound, which I know that some of the investigators here at GW have been very involved with developing biomarkers, new cancer biomarkers. How do we bring these new technologies for screening into policy and particularly into clinical practice recommendations? And how can these recommendations actually keep pace with the development of the technologies? And so.
Yeah, well, absolutely. In a lot of domains, well, we need better screening tests. So the biggest challenge in the domain of mammography is we need a replacement for the mammogram. So we need a more valid, precise test. And we're certainly investing research dollars and as you mentioned, biomarker approaches, screening approaches. And in this area of precision medicine and precision screening that we talked about earlier, stratifying populations according to risk. So taking into account who's at higher risk, who's at lower risk, not treating every patient the same. So that's kind of the outmoded idea. And in a couple of decades from now, we'll probably look back on this era and laugh at ourselves that we had screening guidelines simply based on age and no other risk factors or criteria. So we still have a fairly primitive approach to early detection and screening. And now we can look at genomic markers for risk. We can look there's risk prediction models that have been developed that incorporate lifestyle factors, for example. But also we have to recognize that there are tests that are effective and that simply aren't being used enough. And colorectal cancer screening is probably the most visible case of underutilization and where we know we could substantially reduce mortality to colorectal cancer in the United States if more individuals, eligible individuals, typically over age 50, are screened for colorectal cancer. So in some domains of cancer screening, it's an issue of utilization and uptake, where we're just not getting it out and it's not being utilized enough. In other cases, it's clearly where we need to develop better technology. And most recently, a lot of controversy, of course, about prostate cancer screening. And I think prostate cancer, we need a better biomarker than the PSA, no doubt about it. And one of the things we have to be careful as we develop these new technologies is to make sure they're validated on large populations, so they're not applied prematurely. But at the same time, this is a real challenge for the cancer research community, developing better methods of early detection.
So what I would like to add is also looking at the future with the technologies and the analytics tools that we have. So these large cohort of patients are going to perhaps lead us to identify early markers of cancer development. So right now we are making significant advances in what is called the liquid biopsies. So looking at circulating tumor cells or DNA. And as we enroll the patients in these cohorts and follow them prospectively, so perhaps with new technology we will be able to identify biomarkers of early cancer development. And also biomarkers too are going to allow us to say if this patient has this biomarker, it's likely that it's going to have a more aggressive disease. So therefore we need to start thinking about early intervention. I think that the future is bright in that in the field of prevention.
Mm-hmm. Well, it's maybe the female on the stage. I would add to the criteria that you put. Let's first find a breast screening methodology that is less squishy, and I got a laugh from that. And I do think that there are issues about how the third-party payers take the recommendations and make it very difficult for clinicians to, if you may, individualize how they do screening.
Yeah, no, I think one of the big challenges in the cancer screening domain is that in order to conduct rigorous, large-scale randomized clinical trials of cancer screening modalities, those are very large, very expensive studies. Yeah. And so that's a real challenge, because what it means is it limits the number of large-scale screening trials that we can run. And that's why it's really key that this is a global collaboration, because screening trials in Europe or Canada or in the US or Australia, whatever it might be, it's this consortium of a global effort on cancer screening technology and methods is really essential, because the US can't do it alone, and the size and scale of studies that we need to definitively answer these questions is a real challenge.
So I want to kind of turn to a different challenge and maybe start with Eduardo. But as you're starting to build, this vision for a cancer center at GW and thinking about not only the clinical science, the population science, but also the basic science, it's evident that there is going to be a lot of data, and we are kind of moving into an era of big data, whether it's data that's generated from omics or population data otherwise. And GW has begun to build capacity there. We have our data clusters now that are up and on the Virginia campus. We now do have a systems biology center. We have some emerging, capacity to analyze those data. I mean, arguably our biostat center folks, I see a couple in the audience have already been doing that, and serving as coordinating centers for NIH studies. And certainly we've, in public health, been able to do things like handle the Medicare data set, and things like that. But that's, I think that we've just been scratching the surface in terms of what we might be looking at in terms of, if you may, just quantities of data, but also complexity of data, and difficulty not only in managing it, but actually deriving information from it, which is what we really want. And what your thoughts are about that as we build the center, what the needs are going to be, how you envision that the Cancer Center will need to take that on.
So I think that in my prior faculty appointment, so I was involved in the creation what is called, this initiative called Total Cancer Care, that now has led to the creation of this consortium of cancer centers to deal with big data. And just so let me start by saying that this Total Cancer Care is a protocol. In basically, every cancer patient coming to a cancer center will be asked 3 questions. So one is, can I follow you through your lifetime? Can I collect your data? And can I use your cancer tissue for molecular studies? This protocol started in 2006, and at that time, the molecular study was gene arrays. So these days is omics, and different type of omics, and 5 years from now, so who knows who molecular study will be performing in tumor biopsies or circulating tumor cells. So through that protocol, around 100,000 patients were enrolled in one center, in Moffitt Cancer Center. But it was clear that at the beginning, one of the major obstacles was where to put all this data, because we were collecting demographic data, lifestyle, diet, risk, and also we were adding gene array data, exome data. So rapidly we realized that we needed to partner with the private sector. And that was, Moffitt was able to partner with a pharmaceutical company to create this large database. And then you have the fundings, but then you realize that it's easy to enter data, but it was more complicated to make sense of that data. And then you have to have governance data, and so the investment became bigger and bigger and bigger. But at the end of the day, so they were able to figure it out what is needed to create this database. So they create what is called a health research informatics system. So now with this protocol has become the base for the creation of a consortium called Orion, in which up to today, 10 cancer centers have joined effort to use the same protocol that was developed in Moffitt and start to share some information. Because the idea through this big database was, if we have this mutation in patients with breast cancer, so then we can have this drug specific for this mutation, what is called the right treatment for the right patient at the right time. But then we realized that with one institution, even with 100,000 patients, just to identify a subgroup of patients that can benefit from this treatment, it was not enough. So you need millions of patients in order to be able to identify the frequency of these mutations and also enroll patients on these target therapy clinical trials. So, and that's the reason why Orion, this consortium, was created. And right now there are several consortiums ongoing in the United States, and I think regarding your question about GW, I think that we don't need to reinvent the wheel. What we need to do is just look at these different consortiums and partner with the one that fits our the phase in which we are in initial growth.
Yeah, I think that this idea of research consortia is really key, and I think for any cancer center or medical center, school of public health, in terms of planning how to scale up big science, there are a lot of great models, and there's been a lot of progress out there. Consortium among the cancer centers have been key. We just had a meeting recently of our epidemiology cohort consortia. We convene all the investigators who lead all the large epidemiology consortia from around the world, and they're pooling data, doing very large, genome-wide association studies, molecular epidemiology. That's been key, and this is really going to be what's required to make progress on rarer cancers. Yes. It's not surprising that most cancer research investigators are studying breast cancer, prostate cancer, colon cancer. That's terrific, but we've got this whole suite of rarer cancers where the barriers to studying them and making progress is, well, I only have 4 or 5 or 6 of those patients at my center. So collaborations across institutions, developing informatics capacity to link the basic and clinical and epidemiological data. And again, breaking down these barriers across the sciences. We need the clinical trialists to be comfortable collecting epidemiological exposure data of their patients. At the same time, we need the public health scientists and the epidemiologists to be comfortable collecting treatment data. Because to understand long-term outcomes, we need better and more complete treatment data. And then also we need the social scientists more comfortable with the biological space, collecting samples, which are so key to understand the fundamental mechanisms. But that all requires scale, it requires capacity, and it requires collaboration. And it really requires a change in mindset of how we train our students, whether they're medical students, public health students, or those working in the labs. And that is getting more of our students comfortable working across boundaries, working in larger scale teams, and then also public-private collaboration, because a lot of the data capacity and expertise in our country resides in the private sector. We recently funded at NCI several cloud pilot projects to try to take advantage of how to scale up cloud computing for genomics. But we've got a tremendous expertise to be leveraged in the energy sector, in the data analytics sector. We've been looking at what NASA's been doing in terms of their data capacity. And this was really key in the Genome Project, where we had a great collaboration between the NIH and the Department of Energy in terms of building the computer capacity to understand genomics. So I think it's really a revolution in terms of not only the kind of work, but also a revolution in terms of how we do the work and the interdisciplinarity, which is really a prerequisite to make progress.
So if I can ask the two of you a question along these lines, how do we break down the silos? So I'm just thinking about how, it was about maybe 15 years ago, a decision was made, I think NCI was involved in this. There were 2 large childhood cancer research consortia, and to bring them together to have one, which then covers virtually every case of childhood cancer in the country, and so that you basically have a registry of all of the childhood cancers. But they did have to work together to standardize the variables to make the data compatible. But they did so. They were willing to do so, but it required a lot of federal leadership. And I'm also aware of this effort that the National Human Genome Research Institute has had underway called PHENEX, to try to standardize on phenotypic and exposure data, at least basic data, so that at least every study that's doing genome analyses could accompany with the genome analyses basic, kind of phenotypic and exposure data. So if we can all, ask the same questions about smoking, so that we can put those data together, right? That it's a simple idea, but it's actually complicated because there are people who, are working on making that a better question, right? But, that's kind of where that stands. And, is there progress along those lines, or is this like the medical record where, we're all, groups are adopting their own electronic medical record, but those those electronic medical records don't exchange very easily.
I think it's such a huge issue that you've got to be careful not to fail by trying to boil the ocean. And so I think what's been helpful is focused efforts on data harmonization, standardization in particular domains, different content domains, whether it's genomics, clinical data, EHR data, or exposure data. So we've had a focus effort on outcomes assessment, the PROMISE initiative for patient-reported outcomes, for example. And then you mentioned the Phoenix Project for epidemiological exposure data. And then we've got similar efforts going on in a lot of these different sectors. So you need a focused effort within these content domains, and then you need those to be brought up. And it doesn't necessarily mean that you're going to create one standard formula, because oftentimes through APIs and other informatics strategies, you can still merge and harmonize data. And so a lot of the largest healthcare systems has worked together in one of our consortia, the HMO Research Network, which is really a federated data set model where everybody holds onto their data, but you can analyze and run analyses against those data that still resides within each of those healthcare provider systems and payer systems. I think the private sector has been doing this a lot. Companies like Optum and many others have been applying data analytics capacity to merge claims data, outcomes data, clinical data, prescription data. And that's really been accelerating our progress in understanding post-marketing surveillance of drugs and adverse events. But I think we're just still really at the early phase of this scale-up and utilization of data analytics at a very massive scale.
Yeah. So I agree, harmonization and SOPs are extremely critical, and that's the foundation of this consortium, Orion, in which they share one protocol, which is what I refer the Total Cancer Care Protocol, and therefore there is harmonization of the data. But one point that I want to mention regarding the prior question is, so big data, so the collaboration between different cancer centers, but we need also to keep the patients as part of this initiative. And so having patient representatives, minority representatives, because at the end of the day, this is their data and this is their tissue, and they are donating this tissue and data to us, and what they are looking is for better treatments, and the faster that those treatments occurs, so that the large majority of cancer patients will benefit with. So I remember while we were managing this patient data, so there was a question whether we can share this data with the private sector. I mean, of course, there is HIPAA regulations, but some mutation data. And we convened the patient advocacy group, and the first thing that they said is, this is the tissue, this is the data, use it. We want faster treatment, so we don't care. I mean, of course, there are, again, privacy issues that were respected, but they really want their data, their tissue to be used. The faster, the better.
So I see in the audience actually a person who is an attorney here who often gets involved in some of the ethical issues around the work that we do. And this big data area, and you mentioned this in terms of the privacy question, just raises huge ethical concerns in terms of the accessibility of potentially data that can somehow be reassembled to create an identity, even though you think it's not identifying data. What are the assurances that we're going to need to be able to provide as we move into this arena, and your experience, the two of you, with being able to assure the confidentiality of patient data in this big data era?
Well, I think privacy confidentiality is a hugely important area, but from a science perspective, there are science approaches that can be brought to bear to address issues of identifiability and confidentiality. So just as we develop kind of the science of informatics and data exchange, whatever, there's also a great wealth of expertise into the strategies we can use to address confidentiality and prevent identifiability. So I think one of the issues moving forward is this is a field that also needs to be developed to enable big data and big science. And I'd recommend to you a new National Academy of Sciences report just recently released on the science of team science, which talks about a lot of these issues. But I think we need to train more people with expertise in this domain.
So what we did is we created this patient advocacy group, but also an ethics committee to help us to deal with this issue of, collecting data and sharing data.
Great. Well, I could keep on asking questions, but I think it's time now to bring forward questions from the audience. I know that we're webcasting, and therefore I would ask if you have any questions that you come to the mic if you can, or raise your hand and someone will bring you a mic. And I know that also there are questions that are possibly coming through to us through the Twitterverse for those who are listening in on this webcast. So as people come forward or begin to identify themselves as questions, maybe I'll do just a brief follow-up on something that was just said. And that is that you mentioned the fact that this is in a context increasingly of team science. Mm-hmm. And that's something that I'm excited about personally. I think that it's been a great move forward, that we've talked about interdisciplinary or transdisciplinary research for a long time, and now finally people are doing that. And how you see that developing in the context of these cancer centers across the country, potentially ours, perhaps starting with you.
Well, I mean, the history of the Cancer Centers program is interesting because as I've seen the program evolve across the country, what's really been demonstrated is the convening and catalytic power that a cancer center can have in a university. So bringing together scientists from the basic clinical and population sciences, but also I think it's really important to look across the entire university and leverage the expertise that are in arts and sciences. And that's something that's oftentimes underutilized at a cancer center. We need geographers to be involved in cancer control right now. We need people with expertise in cultural anthropology. We need economists. We need mathematicians. We have a whole large initiative this last few years that we've been funding the National Cancer Institute on the physical sciences of oncology, where we brought physicists together with oncologists on what are the perspectives that the physical sciences can bring in terms of understanding how a tumor works and operates and functions. So a cancer center can be a catalytic force, a convening force, but also a bridge to the community that really allows the faculty to re-engage how you work with the community, how you meet and serve the needs of the community, and also how you listen to the community in terms of tailoring the services, the programs that are provided by the university to those who are in greatest need.
So yeah, I am a big fan of teen science, and so I've been here for 4 months, and so one thing that I have been doing is meeting with a lot of the faculty, and so what we have done is what we call internal recruitment. So I was able to find, for instance, very good scientists in the microbiology, immunology field, tropical medicine, and parasitology. And one of the parasitologists is working in what is called transgenic parasites. And so we start talking about the idea of using transgenic parasites to deliver cancer therapies. Although it sounds like a crazy idea, but so this is the group that has the tools and the knowledge to make it happen, or at least show if whether it's going to work or not. So the other area of strength here at GW is in policy, politics, and so we are creating a group that is going to focus on cancer policy and involve economists, lawyers, population scientists. I think that so what team science allows us is to bring our knowledge, our expertise to try to focus in on a specific problem, cancer related.
I think a lot of people, when I go around and visit cancer centers or giving presentations to communities, a lot of people are surprised when they ask me, well, what's the most effective policy action we can take to reduce cancer mortality? And I say, increase excise taxes on tobacco products. Excise taxes is not typically a topic of discussion at a medical center or even in a cancer center, but it's a great example how oftentimes the biggest movers in terms of public health and cancer control are these fundamental policy issues, whether it's extension of coverage in terms of healthcare access or in this case excise taxes on tobacco products. The big drivers of cancer mortality are still some of the ones that are most obvious And oftentimes for people, these are old topics, but they're not solved. Tobacco use is still by far the leading cause of cancer death in the United States. And now we have obesity coming up. And what's remarkable is that most of the public is not aware that obesity is a risk factor for cancer. And that's a huge educational gap we have to fill, not only with the public, but with our policymakers who say, well, tell me what I could do to help the war on cancer. And then I said, well, tell me what you're doing to support work on controlling obesity. And I said, well, what does that have to do with cancer?
They don't know.
Yeah, they don't.
They don't know. And it is interesting how much of the epidemiology will focus on a food as potentially being a risk factor, whereas it's probably the calories that are in the food that are the problem. But we also, by the way, have on campus, we have a law school, which gets very involved with us in health policy. We also have a school of engineering, and I see the dean of engineering here. And I do think that there are opportunities to engage with engineering on many of these areas. I don't know, David, if you want to say anything about that from your perspective or the perspective of the school, but not only the obvious nexus of interest with biomechanical engineering and the work that we might be doing on therapies, but also on rehabilitation of people with cancer, but also maybe even systems engineering and trying to understand how to make the system work better. But Dave, I don't know if you would like to add anything. He needs a mic. The Dean Darling needs a mic. I don't want to put you on the spot either, but he is here. So why not?
Welcome. It is on, yeah. Thank you, Lynn. I actually, for once, don't have a lot to say. I came here to listen, really. I know that our chair of biomedical engineering, Igor Efimov, has been talking to our new cancer center director about cancer engineering possibilities with respect to programs and faculty. But your point about systems engineering is a good one, too, and I think we'll have to follow up on that. So that's basically all I have to say, but I think there's certainly a great opportunity for us to collaborate with the Cancer Center here. So thank you.
Yeah, so along those lines, the Cancer Center is going to be in the same building with the engineers are, and that provides actually the proximity that is needed for collaborations. And so in the one developing program in the Cancer Center is called Cancer Engineering, and what we are looking is to try to develop novel technologies or nanotechnology for delivery of cancer therapies, but also new diagnostic tools, improve our imaging studies for early detection. And so we are working with the director of the Department of Biomedical Engineering, and my expectations are that good things are going to happen just by bringing together engineers, cancer biologists in the same building.
Yeah, the progress in nanotechnology in the bio-nano space in the last few years has been really remarkable, and I think in terms of looking at new strategies for drug delivery at the molecular level and the kind of the characterization of function and structure and the links between physical chemistry and the nano domain have really been remarkable in the cancer field, and we've really benefited in cancer research by bringing the nano community into cancer research in a really substantial way. And I think that's going to continue to pay dividends.
So one of the exciting features of our new science building, the Science and Engineering Hall, is that there is a nanofabrication core. And I think that is a commitment on the part of the university to begin to build that capacity here. But I also think there's the ability of people from outside of the university to be involved in that. So just wanted to mention that as an aspect of that.
I think collaborations, we have NCI supports a nanotechnology characterization laboratory out at Frederick. And we work closely with NIST, National Institute of Standards and Technology, in terms of trying to develop standards in kind of the bio-nano interaction. And I think it's a great area for public-private collaboration as well. Opens up a lot of opportunities. So it's an exciting area.
There's also a lot of interest in my profession in environmental health not only the characterization of the materials, but also what's happening to the materials biologically and in the environment, which we don't yet understand very well. And it's very critical, but we have somebody at the mic. Yes.
Can you hear me?
My
name is Tala Fakuri. I'm an epidemiologist with the CDC, and I was a bench scientist in a previous life. I have a question to Dr. Croyle about how do you engage basic scientists who are really interested in answering questions that may not be related to anything, to cancer now. They just want to know, how does gene X affect the development of this organ or that organ in C. elegans or in Drosophila? How do you engage these basic scientists in the context of very limited budgets for research to be a part of the PMI initiative?
So I'll give a practical, maybe a little cynical answer, and then maybe one a little bit more lofty. What population scientists oftentimes have to offer to basic scientists are access to people, access to tissue, access to data, and that is that once you're trying to move something out of the laboratory, or let's say somebody works with a mouse model or a cell line model, whatever, trying to engage the research question that they're interested in. And once that moves into human populations, that's where those collaborations are really key. I think the other thing too is that the non-basic scientists need to learn how to communicate their science better to basic scientists. Oftentimes, I think I hear behavioral or population scientists say, I'm trying to work with a basic scientist, and I just can't understand what she's saying. And I said, well, can't she understand what you're saying? And so trying to learn to speak each other's language and also appreciate the methods used by each other's areas of science, I think is really key.
Thank you.
Sylvia Silver from George Washington University. Dr. Sotomayor mentioned the fact that the patients really want research done. And I run a biobank. And HIPAA has caused more problems with trying to reach patients. In fact, now the discussions about changing the common rule are really concerned to biobankers. So what do you do with the fact that you want to protect the patients, but the patients would rather not have to have people go through all these hoops to try and reach them, to ask them if they could use their specimens, because the amount of research has really decreased because we can't reach the patients. The physicians don't answer us, or they don't understand that they're really the way we can reach the patient. So I'm finding that, yes, people want research done, patients want research done, but the researchers really can't get access to the patients unless they go through a lot of hoops, which sometimes don't work. So what's your suggestion?
So let me just give you so before we have this system, we need to have a sort of what we call a universal protocol for tissue collection. And what we have currently right now is several islands of protocols, and they don't, so basically are not formulated to have these, from the beginning, answer the issue that you are raising. So with this protocol, we have the patient consents, and this has been reviewed by lawyers, by HIPAA, by patient advocacy groups, and they clearly tell us that we are allowed to use their tissue for not only for collection but also for molecular studies. So having that a unified protocol actually is going to help to solve this issue that you are mentioning.
But I do think that Dr. Silver is raising an important point, which is that there is retroactive application of today's legal advice to things that had excellent legal advice 10, 20 years ago and were collected per that excellent legal advice, but it's now different. And I think that is a very difficult issue, and it might be worth having a special symposium on, because there is work underway to modify the common rule, and we'd hate to see the loss of a lot of historical data. The historical data are very important and contribute tremendously to our ability to do research, and yet, it is often just absolutely impossible to go back and contact people, especially if you think that you discarded their identifiers, which is often the case. But now you're told, well, it's identifiable because you have tissue. Well, try to use the DNA from that tissue to identify the people and then recontact them to reconsent them. Good luck with that. That is not going to happen. Next question.
Hi, I'm Madeline Halpern from ICF, and I was wondering what you can do to make sure that the policy stays pace with the research so that you don't have people saying, well, if mammograms aren't very effective, maybe if everyone has dense breast tissue, we're going to give them all ultrasounds, and that may not be the most effective way, actually, since it hasn't been studied long-term to check those cancers, but California has that policy now. So how do you make sure that the science and the policy are not running at different speeds?
Wow.
I'm not sure that there's an answer.
No,
I'm not sure there's truly an answer
Well,
to that question.
This issue of how do we help policymakers be better consumers of evidence, of science, it is huge in this context and all these contexts. And that's why I think you need really effective mediators, communication mediators, who work in an intermediate role in terms of explaining, clarifying, simplifying science and science evidence. So health communication is really key here, and folks who've worked in the policy world know that the typical request by any member of Congress to their staffer is, gee, this is great, but could you get it down to a half page, and then I'll read it. And scientists often are not great at that. And effective science communication and being able to distill evidence, especially data, down to a digestible form that policymakers can consume. That's absolutely essential and enormous. The other thing is that we need to do better in getting our scientists in the scientific community engaged in policy issues. This issue about, every scientist knows that HIPAA is a barrier to research, but how many scientists are engaged in advocating for revising HIPAA regulations? Not many.
So if I can add, so within this cancer policy program at GW, that's what we want to bring, the different stakeholders, basic scientists, population scientists, clinicians, patient advocacy group, and pharma. And then, so we have the lawyers at GW and formulate the half a page that you are talking about so that they can go and convey in a good way the consensus of this group of stakeholders. So bringing science with policy will require, I think, a framework, and that's what the cancer policy program that Dean Goldman and us are trying to build.
I think we will probably be most effective in the context of FDA, CMS, AHRQ, possibly not very effective in preventing things like individual states from enacting laws, and you can't, they read your half page, there are other scientists who'll give them a different half page that will say something different. And because almost any point of view, there's a scientist somewhere espousing it, right? And so, the best you can do is to try to establish that your science is more authoritative, that it's more vetted, that it's got more consensus, around all the scientists. And even then, sometimes policymakers don't listen. So that's why I was saying there isn't completely an answer to your question, because the policymaking process isn't fundamentally a science process. But next question.
Hi, I'm Tim Newmas, a doctoral student at Morgan State University, and my area is health literacy. So when I heard you say health literacy, I jumped up. A lot of times we don't talk about that issue, but I'm listening to the conversation and writing about that. That's one of my areas of my dissertation focus is health literacy, particularly for men of color, which is an organization that I've started prior to getting my master's degree at the University of Baltimore. So when I heard the conversation, I'm concerned about the cultural sensitivity issue and how you're dealing with that, whether or not social marketing is something that you're looking at, and how are you actually breaking down those barriers so that information along those lines are actually getting to the people that you want to put into clinical trials. A lot of the sensitivity around that issue is probably because of those historical factors or those other issues that impact people of color, and so therefore they might not want to be in clinical trials. So my whole focus is changing the way health literacy is done in those particular situations.
Yeah, no, I think that's why the last several years we've invested research dollars in health literacy research, because I think it's just as important as any other domain of research. We funded, for example, a Center of Excellence in Cancer Communication Research at St. Louis University and Washington University in St. Louis, led by Matt Kruder, that was really focused on how do we communicate about health disparities to African American communities, where they found that the communities were engaged in the issue, but the way it had been framed in such a negative frame was not enabling action or response. Eventually, what that NCI-funded research project evolved into was an Ozioma news service with black newspapers around the country, which provided a channel to deliver, up-to-date cancer research evidence to the community, but again, adapted and tailored to local cultures in a way that would resonate and communicate effectively. So I think one of the issues that we're going to really sustain in the next several years as a research funder is value communication research, just as we value biological or drug development research.
One last question. Sorry.
Good morning. My name is Tanja Kyle with ICF. Early in the presentation, we discussed the impact and benefits of the Precision Medicine Initiative. We also touched on the need to enroll more underrepresented populations and to ensure a more complete health picture. Beyond the goal of creating the million-person cohort, and considering today's focus of being at the crossroads between clinical and population sciences, what do you see as the biggest challenge facing the Precision Medicine Initiative, and how would you recommend overcoming those challenges?
So I think the major challenge will be finding the sustainability of the model. So it's good that the government is giving us the big start-ups, so with this cohort, but so we need to demonstrate that value, that precision medicine is the approach to lowering the cost of delivering cancer care in the not only in America but in the world. So it is expected that by year 2020, so the United States is going to spend near $90 billion in cancer care. And with personalized precision medicine, what we are looking is give the right patients the right treatment because we are going to identify biomarkers. So that's the hypothesis. By identifying biomarkers, we will be able to deliver better care. So there is going to be less admission or hospitalizations because we are going to be understanding how a particular patient will respond or not to a particular therapeutic approach. So that's the promise of personalized medicine. So we need to create the scientific basis to show that it works. And I think when we show value, then we are going to be able to have a sustainability model. And I think that the private sector is going to play an important role in working with academia and the government. So we had a great start with the Precision Medicine Initiative, but it's going to be, we need to be creative about how to sustain the model.
Yeah, I think and a lot of that sustainability comes from developing creative ways to lower the cost of large-scale population research. So one of the funding announcements that we released last week related to the Precision Medicine Initiative is a whole component just focused on mobile health technology and using mobile technology and creating a whole resource for the PMI initiative so we can collect data and enroll and communicate with participants through their mobile devices. And we've got a lot of good creative examples around the country. In California, one of the cohorts we support is using Salesforce.com, their IT infrastructure and online software infrastructure, as a way to manage all of their participants in their research, recontact or whatever. So I mean, leveraging technology to lower cost. I think the other thing in terms of the sustainability issue and a challenge with the PMI initiative, the 1 million cohort component, is how do you balance breadth versus depth scientifically? Because to answer a particular specific scientific question or a hypothesis about disease etiology, you need a lot of measures about a lot of risk factors related to one particular disease. And we know from the National Children's Study experience, we have other large-scale projects where there's tension between doing a lot of things, but maybe superficially, doing versus a few focused things and doing them in depth. There's just a constant creative scientific tension between that. But I think one of the ways to address that is, again, by trying to really figure out how to utilize new technologies to lower the cost of conducting research. That's a must.
All right, so this is, as most of you know, this has been a series of symposia that's a partnership between GW and ICF. And to close this session, it's my pleasure to introduce to you Sudhakar Kesavan, who's chairman and CEO of ICF International. I'm going to move up to the podium here to welcome him to it. Since he took on this leadership role, he has led ICF through a leveraged buyout and an IPO. That's kind of an unusual experience. He was named Tech Titan and Industry Leader by Washingtonian Magazine in 2013. In 2009, he was recognized by the Professional Services Council, Fairfax County Chamber of Commerce's Greater Washington GovCon Council, and Washington Technology Magazine as Executive of the Year. He is a board member emeritus of the Rainforest Alliance, a New York-based nonprofit environmental organization that protects the ecosystems. In addition, he is an active supporter of Impact, a nonprofit focused on primary education for girls from economically and socially underprivileged rural areas of India. This, by the way, is a great interest of many of my faculty. Mr. Kesavan has a bachelor's degree in chemical engineering from the Indian Institute of Technology, a postgraduate diploma in management from the Indian Institute of Management, and an MS from the Technology and Policy Program at the Massachusetts Institute of Technology. Welcome.
Thank you very much, Dean Goldman. I want to thank all of you for attending today's session. I also want to offer my thanks to President Knapp, Dean Ackman, Dr. Croyle, Dr. Sotomayor, for taking the time and for being here and helping us continue the high-quality programming which we have been able to achieve in this series. I was reminded, talking about interdisciplinary research, that I went to the Technology and Policy Program, as Lynn said, at MIT, and this was many, many years ago, in the early 80s. And every time we wandered around talking to the basic scientists or the engineering school, they all wondered how we got in to MIT, because it was supposed to be an institution for pure sciences or for pure engineering. And therefore, interdisciplinary research was not quite the thing there. But obviously, the dean there had recognized the fact that something has to be done about public policy and technology. And I think that was a program which had just been started and, in fact, has prospered since. And now there is a whole Institute for Data Systems Analysis, which has been set up to help further the whole systems engineering and data analytic programming at MIT, so that we can put all these disciplines together. So it really is a terrific thing to hear that there is more respect for interdisciplinary research now than there was perhaps 30 years ago. I think we at ICF, if you're not aware, believe that the work we do does help the world a sort of a better place. We do this work in many diverse areas, including energy efficiency, climate change, human trafficking, and, of course, health. Specifically, as our work relates to cancer, we support the National Program of Cancer Registry's cancer surveillance system. We have helped to redesign the cancer.org website for the American Cancer Society, and we contribute to important research on the Smoke-Free Program, the Health Information National Trend Survey, and many other cancer-related research programs. Our work with the Department of Health and Human Services and the National Cancer Institute help people stop smoking, and in recent years we've received awards from the North American Association of Cancer Registries and from the National Institutes for Health for our work supporting efforts to combat cancer. We are proud of the work we do to address cancer. Perhaps it's the personal contact, though, which with the disease, that hits us usually very close to home. It is difficult to find anyone, anywhere, who has not been touched directly or indirectly by cancer. We know the statistics all too well. Roughly 1 million people are diagnosed with some form of cancer each year in the United States, and nearly 600,000 die from its ravages. Cancer also imposes enormous direct and indirect costs, from an estimated $90 billion cost burden per year in direct medical treatment costs to obviously the less quantifiable emotional costs associated with the diagnosis, treatment, survivorship, and end-of-life care. Few, if any, health topics are more deserving of our attention, and that is why we are teaming with GW to bring this series to you. Let me end by offering my congratulations to everyone who participated and attended today's event to help improve lives of those with cancer. and for dedicating so much time and effort to this cause. Thank you very much and have a very pleasant afternoon.